I'm Professor Aziz-ur-Rehman, and today I'm going to start a series of lectures on calcium-related disorder. And the first of the series is an introduction. I guess if you go through in the proper sequence, you will understand this business much better. So start with this introduction, and then if you find time, see my videos on hyperparathyroidism, hypoparathyroidism, and vitamin D deficiency states. Uh, Calcium homeostasis is extremely important. Calcium is very essential for life, and it is maintained in a very narrow range, in a very narrow physiological range, because even slightest derangement in calcium level can cause a lot of problem, because it is involved in nerve function, muscle function, cardiac function, intestine function, our vascular tone. So it is very important to keep it within a physiological range. And there are certain hormones which are responsible and certain organs which do the job. Parathormone is a hormone which is also abbreviated as PTH or parathyroid hormone. It is secreted by the parathyroid gland, and it has got an extremely important role. Most of the important role of parathormone is to keep calcium level in the blood. It's to raise calcium level. And then we have calcitonin, which is another hormone which is produced by some specific cells from the thyroid gland, and its actions are mostly opposite to the effect of parathormone, but it has got weaker effect than parathormone. Then vitamin D is a vitamin as well as a hormone. When we ingest it or when vitamin D is produced in the skin, it is inactive, but it has to be activated to become a hormone. And that also plays a very important role. So these three hormones, they work in very good harmony to keep our calcium level from getting very low or from getting very high. So organs which are involved, parathyroid glands, we have four of them. Some have more, some have less, but they're on the average there are four glands, very small in size, and they are attached to our thyroid gland, and they function as one structure. Then we have a very important role of intestine, what the food we take, where that is absorbed from the gut, and this requires the help of vitamin D, and vitamin D in turn needs the help of parathormone to do that function. And then bone, of course, bone provides the structure to our body, but bone also acts as a reservoir of calcium. So whenever we have excess calcium, it is absorbed by the bone and deposited there. And whenever there is a deficiency of calcium, the calcium is mobilized from the bone and serum calcium is kept normal. And kidneys, again, because kidneys excrete calcium, so the job of kidney is to prevent too much excretion of calcium, so that the calcium, being a very essential nutrient, is not lost in the urine. So these are the hormones and these are the organs which have very important role in regulation of our calcium. As I told you earlier, calcium homeostasis is one of the most perfect homeostasis in our body. Calcium level is kept within very narrow range despite variation in our diet and our activity. So because it is extremely essential for nerve function, and even slightest derangement in calcium level reflects a serious underlying disease, because calcium gets deranged only when this very sophisticated system gets overwhelmed. Now, this is how our extracellular fluid calcium is maintained. You can imagine that it is extremely narrow range. Now, various hormones which play their role. First of all, is PTH. PTH is parathormone released by the parathyroid gland. It has got stimulatory effect on vitamin D. Vitamin D is activated into its active form, which is 1,25-dihydroxycholecalciferol. The one we ingest in food is not active. The one which is produced by the skin in the presence of sun is also not active. But once vitamin D is activated by parathormone, it helps the absorption of calcium from the gut. Our diet contains a lot of calcium in various forms, and we may also be taking calcium in supplement form. So that calcium cannot be absorbed unless there is active vitamin D. So parathormone through vitamin D helps to raise serum calcium level or to maintain it at a certain level. And then parathormone and vitamin D both have effect on the bone. You know, bone is actually a reservoir of calcium, and calcium may be mobilized, or maybe if there is reduced serum calcium, then parathormone will stimulate osteoclast, and osteoclast will mobilize some calcium from the bone and will release into the extracellular compartment, so that the serum calcium level or the calcium in the extracellular compartment is maintained. So parathormone does whatever it needs to maintain the calcium level. Third role of parathormone is to prevent calcium loss in the urine. So this is negative mark, negative sign. So like any solute, calcium would be excreted by the kidneys, but parathormone reabsorbs it and bring it back to the extracellular compartment. So you can see that as if parathormone is obsessed to raise serum calcium whatever way it can, by increasing absorption from the gut, by mobilizing calcium from the bone, or by preventing its excretion into the urine. In parallel, we have another system which works in harmony, that is calcitonin. Now, I think before we talk about the calcitonin, once serum calcium level is sufficient, then it has got inhibitory effect on parathormone, and further production of parathormone is stopped and calcium level is maintained in a narrow range. So parathormone alone with the help of vitamin D is good enough to maintain our serum calcium, but nature made another backup arrangement, and that is with calcitonin. Calcitonin has just the opposite effect, but as I said, the main regulator of our calcium is parathormone. Calcitonin works only when needed, and only it has got just the opposite effect. It would have effect on the osteoclast and to slow them down so that the calcium is kept in the bone. So calcitonin, in other words, will promote deposition of calcium in the bone. So in other words, it will tend to lower the serum calcium. It will of course take the calcium from the extracellular compartment and deposit it in the bone. That is why calcitonin is also used in some hypercalcemic state and also in osteoporosis. Then calcitonin has effect on the kidneys. It promotes excretion of calcium when we have too much calcium. So calcitonin will work when there is hypercalcemic state, and it will bring the calcium to the bone, and it will also promote its excretion. So you can appreciate how intricate this system is. Parathormone and calcitonin, along with vitamin D and GI tract, they work in harmony to keep our extracellular calcium in a very narrow range. As I said, even slightest change in serum calcium would indicate something very serious. Now, what can happen when the serum calcium changes? It could be problem with the parathormone. So we will be discussing conditions related to parathormone. It may be some problem with the vitamin D, and it may be gut problem. Patient may not be taking enough vitamin D in the form of diet, or patient may have some malabsorption, or there may be problem with the bones. Sometimes bones, there is a problem with the bones and kidneys. So anything can actually affect our calcium. So we'll be discussing those conditions in subsequent lectures. So as a result, if the calcium is deranged, what are the conditions you can expect? That parathyroid can be at fault. Vitamin D could be in excess or deficient. Similarly, parathyroid could be in excess or it could be deficient. We may not be taking enough calcium in the diet. But I don't think taking more calcium in diet would cause hypercalcemia because our system of regulation is very, very efficient. But if diet is critically low in calcium, that of course would result in hypocalcemia. Then kidney disease, chronic kidney disease is characterized by hypocalcemia and malignancies, very important. In fact, after parathyroid gland, second most important condition which can affect our calcium is malignancy. Several malignancies because they make metastasis in the bone and they mobilize calcium from the bone, and they may also produce a parathyroid-like peptide and which also raises calcium. And there are several other diseases actually, and we will not be able to discuss them in detail here. What is the role of calcium? I will not be able to go into the detailed physiology, but I would say that it is extremely essential to maintain normal biological function. All excitable tissues in the body, like our neurons, like our nerve cells, like our skeletal muscles, like our smooth muscles, like our heart muscle, like our conduction system in the heart. So everything is important for life and everything needs calcium. Nervous system I have already mentioned, and musculoskeletal system and blood coagulation. If you remember your hematology, almost every step in the coagulation requires some calcium. But you probably have not heard that hypocalcemia can cause bleeding disorder because you actually need a very small amount of calcium for clotting factors. So before one develops that much hypocalcemia, patient would actually present with other symptoms. So I believe hypocalcemia usually does not cause any coagulopathy or bleeding disorder, although it is very essential for normal clotting. Bone diseases, it is very important to maintain our bone health. If there is not enough calcium, it could result in softening a bone or bone become very, very brittle and some other function. Literally, I believe every organ of the body needs calcium. So calcium has to be kept in a very, very normal physiological range. Now, this is the distribution of calcium. Now, the calcium we have, when we measure serum calcium, we usually measure the total calcium. But all this calcium is not metabolically active. This one is ionized. 50% is ionized, which means it is in the free form. That is what matters. So this is what matters when it comes to body functions. So we really worry about this one. But when we measure it, we measure all this which is bound to the protein also. So this big chunk is bound to protein. This is not useless calcium. It is actually this is in equilibrium with the free calcium. So whenever the free calcium is reduced, the protein bound calcium is released. But as long as it is bound to the protein, it is metabolically not active. Then some calcium is bound to other proteins. Okay. Now, since this is very important, 1 gram of albumin binds 0.8 milligram of calcium. This will come under discussion again when we discuss hypocalcemia. But at this stage, I think you should understand that just hypoproteinemia, even when our ionized calcium is normal and body does not have any problem with calcium, but since protein is less, the total measured calcium may also be reduced. Patient may not have any calcium related problem, but calcium level as measured by the laboratory will show hypocalcemia. So we need to correct it for given albumin. I'll show you in one of the slides how to do that. Calcium related disorders are, we can classify into two groups: those conditions which can cause hypercalcemia and those conditions which can cause hypocalcemia. Here I'm only going to present the summary. Hyperparathyroidism, vitamin D intoxication and malignancies, they cause hypercalcemia, and hypoparathyroidism of various types, vitamin D deficiency, and chronic kidney disease. These are the main examples of hypocalcemia. Of course, you can find longer list in the book, but these, in my opinion, are more important, and you need to memorize only these three. Now, let's take the example of those conditions where there is hypercalcemia. First of all, 75% 75% patient with hypercalcemia would have hyperparathyroidism. That makes your job and my job easy. So if you have hypercalcemia, now my teacher used to tell us that this is a very sensitive test. If you get a laboratory report showing unexpected hypercalcemia, first thing you should do is to reconfirm. So after reconfirming that there is actual hypercalcemia, it is not factitious hypercalcemia, so then you start wondering what may be the cause. And before you consider causes, do albumin level also and make the correction. Now, if corrected calcium is high, only then you would label it as hypercalcemia. So once that is done, then we will consider various possibilities. Since in 75% the cause is likely to be hyperparathyroidism, and I would actually focus on hyperparathyroidism to find out the cause. Now, there will be a complete lecture on hyperparathyroidism. Then malignancies, it could be any malignancy, it could be a malignancy like any cancer. It could be multiple myeloma, it could be any tumor which has metastasized to bones, breast cancer, prostate cancer, testicular tumor. So any tumor I think can cause hypercalcemia. Then vitamin D intoxication. These days there is a fashion of taking vitamin D. I'm using this word fashion, perhaps not correctly, because there is vitamin D deficiency all over the world. But people are taking vitamin D in massive quantities. So theoretically at least, this large quantity of vitamin D can cause vitamin D intoxication, because vitamin D is a fat soluble vitamin. Once ingested, it is not easily excreted. So there is a possibility that there is massive levels of vitamin D, and that can cause vitamin D intoxication. That is another cause of hypercalcemia. But most these days, 75% hyperparathyroidism, 15% cancer, 10% vitamin D intoxication, and all this long list. Sarcoidosis, Addison disease, thiazide type of diuretics, Paget's disease of bone, and thyrotoxicosis. These are relatively less common causes. They will all fit in this 10%. Now, this is how we interpret hypercalcemia. I would like to have your attention here because this is my favorite slide. And there are three conditions I would like to discuss. These three conditions are hyperparathyroidism, malignancy, and vitamin D intoxication. So you have a patient with hypercalcemia, and you are going to differentiate between the three. And you already know that chances are that it is hyperparathyroidism, because statistically 75% would have hyperparathyroidism, only 15% would have malignancy, and less than 10 would have vitamin D intoxication. So with that background, we will carefully examine the blood chemistry. Of course, in hyperparathyroidism, parathormone, which is now we call it intact, because previous assays used to measure only one end of parathormone and used to sometimes give false values. But the modern assays, they measure parathormone from two ends. So that means what is measured is actually parathormone. So we always go for intact parathormone. In fact, all laboratories are doing intact parathormone these days. So in hyperparathyroidism, parathormone will obviously be high because that is what it is, because it's a condition of hyperparathyroidism. Then parathormone hormone related peptide will be absent because that is seen only in malignancies, and calcium corrected will be high because we are discussing the causes of hypercalcemia. And you know, parathormone always increases serum calcium. Now in malignancies, calcium, the parathormone is low. Guess why? Actually, the problem is here. Malignancy may produce, let's take the example of carcinoma bronchus. Carcinoma bronchus, the small cell cancer, can produce many peptides, and one of them may be parathormone related peptide. Now, this is a substance which has got effect like parathormone but is not actually parathormone. So since it has got the effect like parathormone, it will raise serum calcium. Now once serum calcium is elevated, it can't do anything about the parathormone related peptide, but it will have its physiological role and will inhibit the normal parathormone. So parathormone will be low, parathormone related peptide will be high, and calcium will also be high. The third example is vitamin D intoxication. Here, parathormone is low. Again, you may be wondering why. Because actually problem is not here. Problem is here. Vitamin D intoxication has caused hypercalcemia. And because of hypercalcemia, it is suppressing parathormone, because I showed in my earlier slide that serum calcium, if it is elevated, it suppresses parathormone. So it will suppress parathyroid hormone and parathormone hormone will be reduced. So I hope this little chart, this little table will help you to differentiate between three important and common conditions of hypercalcemia. The other rares will be beyond the scope of this lecture, and of course based on other clinical feature we will consider, and of course you have to rule out these first before you consider rare possibilities. Treatment of hypercalcemia. Now, irrespective of the cause, sometime, of course, we need to determine the cause, but sometime hypercalcemia may be massive and hypercalcemia may be an emergency in itself. So we can't wait for the cause to be determined and to focus on the cause. We have to treat hypercalcemia in its own right. So first step is simple hydration with normal saline. So we give large amount of normal saline because it will have a dilutory effect. So the calcium level will not naturally come down. But since we're giving a lot of water, we have to give furosemide because we're actually causing forced diuresis. So that extra calcium is removed into the urine also. So this is one simple step which is possible at any level in any hospital, even at home. Then bisphosphonates, because these are the substances which help to calcium to go to the bone. They inhibit osteoclast and they help calcium to go back to the bone. And calcitonin, again I discussed that calcitonin, if available in the form of injection, can be given. It also promotes deposition of calcium into the bone, so serum calcium will be reduced, and it will also help to excrete calcium from the kidney. And mitramycin is an anti-cancer drug which is used in many malignancies, but it has got its own action on calcium also. Malignancy related hypercalcemia can respond to mitramycin. IV steroids, again steroid can have immediate but temporary role. IV phosphates are known to be very effective because phosphate will bind to calcium, and calcium phosphate will deposit somewhere in the body and calcium level will be reduced, and this can bring down calcium precipitously. So one has to be very careful about IV phosphate infusion. Dialysis If patient has got severe hypercalcemia and is refractory to all, and patient is already has got renal shutdown, because one of the complications of hypercalcemia is renal damage. Patient may be already having renal failure, so I think dialysis would provide the last resort. Now take up the topic of hypocalcemia. Causes of hypocalcemia, just opposite of hypercalcemia, hypoparathyroidism, and I have a separate lecture on hypoparathyroidism, and you can watch that also. Vitamin D deficiency, which is very common, but we have seen patients with vitamin D deficiency these days, but in my experience, most patients who have a reduced vitamin D level, they do not have hypocalcemia. Perhaps because parathormone corrects it. Because of vitamin D deficiency, there is functional or there is physiological compensatory hyperparathyroidism that keeps the calcium from falling. But I'm not exactly sure why, but most patients with vitamin D deficiency in adults, they do not have hypocalcemia. Only in children, when there is severe and prolonged vitamin D deficiency, these patients can develop hypocalcemia. And I have a separate lecture on vitamin D deficiency also. Then chronic renal failure is very common. In fact, in my experience in adults, the commonest cause of hypocalcemia is chronic renal failure. Then malabsorption. Naturally, even if somebody is ingesting calcium in sufficient quantity, but since gut is not absorbing, so this could result in hypocalcemia. Correction of calcium for albumin. Now this is what I mentioned earlier, but this is, I'm going to give you an example which will help you to understand what it means and how to actually make the correction. Now this is an example. Suppose you have a patient and you measure his calcium and it turns out to be 6 milligram per deciliter, which of course is very low. And measured albumin, because whenever you order calcium, I think it should always be calcium, phosphate, alkaline phosphatase, all three together, along with albumin, especially if there is any reason to believe that this patient may have hypo or hyperalbuminemia. So you measured calcium and that turned out to be 6, and you made albumin, that turned out to be 2.5. The normal values for reference serum calcium, just suppose that it is 10. Of course, there is a range, but suppose we expect it to be 10 milligram per deciliter, and we expect albumin to be 4. Okay, so the theory says if there is change in albumin, there may be change in measured calcium, but not in the ionized calcium. So measured calcium deficiency, it should be 10 and the value shows 6. So the measured deficiency is 4 milligram per deciliter. So when it comes to calcium, 4 milligram deficiency is very, very significant, very severe deficiency. And you measure the albumin, and the albumin in this patient, for example, is 2.5 gram. Just examine this. This is a patient who has got albumin of 2.5. So the albumin deficiency is 1.5 gram. Again, very, very significant deficiency. Now, when you make correction, we know this fact that 1 gram of albumin binds 0.8 milligram of calcium. Okay, so because this patient has got 1.5 gram deficiency of albumin and 1 gram binds 0.8 milligram, so the total apparent calcium deficiency due to hypoalbuminemia is 1.2 milligram, which is not the real. It is real in the sense that it is bound to the protein, but it is not what matters. So when we make the correction, the corrected calcium level in this patient would be 6 plus 1.2, actually the value will be 7.2. So 7.2 is also low, but not as low as it was initially thought 6. Now in this patient, even after correction, calcium is low, but there would be cases. Now this is very interesting. You would see some cases where there is apparent modest hypocalcemia. In the same example, if the initial value was 8 would be low, but after making correction, you would appreciate that the calcium level, the ionized calcium level, is actually within the normal range. So this is very important, especially if somebody has additional disease other than calcium. Especially albumin. Albumin comes from the liver, and hypoalbuminemia is likely in chronic liver disease, and hyperproteinemia is likely in pregnancy or somebody who is taking estrogen, progesterone, or things like that. Just like we discussed the differential diagnosis of hypercalcemia, we are going to discuss the differential diagnosis of hypocalcemia. Now, these are the conditions listed here, and we are going to differentiate between hypoparathyroidism, vitamin D deficiency, and chronic renal disease. If you remember one of the previous slides, I mentioned these are the three common causes of hypocalcemia. Now we will measure calcium, and then we will make appropriate correction if patient also has hypo or hyperalbuminemia. We will always measure phosphate, and we will also measure intact parathormone. So in hypoparathyroidism, calcium will be low. Of course, calcium will be low in all three conditions because we are actually discussing the differential diagnosis of hypocalcemia. So calcium will be low in all three conditions. But let's see what happens to phosphate. In hypoparathyroidism, phosphate will be elevated because parathormone has just the opposite effect on phosphate as compared to calcium. Now, parathyroid is trying to excrete phosphate. Parathormone is always tries to excrete phosphate from kidneys. Once there is not sufficient level of parathormone in the body, phosphate will be retained. So there will be hyperphosphatemia. And PTH intact is low because we are actually discussing hypoparathyroidism. So parathormone is low, calcium is low, and phosphate is high. So this is an important point. When it comes to vitamin D deficiency, calcium is of course low, but this is very interesting. The phosphate is also low because vitamin D has effect on calcium as well as on the phosphate. So once there is a vitamin D deficiency, there will be hypocalcemia, and that would stimulate parathormone, and the parathormone will try to correct hypocalcemia. It might actually correct it to a certain extent. So the hypocalcemia is partly corrected, but parathormone will further reduce phosphate because this parathyroid always tries to get rid of phosphate. So in vitamin D, sorry, we're talking about the vitamin D deficiency. In vitamin D deficiency, yes, the parathormone, which is physiological hyperparathyroidism, that will get rid of this phosphate. So existing hypophosphatemia will become even worse. So in vitamin D deficiency, you would have both hypocalcemia and hypophosphatemia, but hypophosphatemia is more regular and consistent and more reliable abnormality because the compensatory hyperparathyroidism might have partially corrected calcium deficiency. I hope I made my point clear. And PTH would be increased. There is no problem with the parathyroid gland, but as a compensation because of the hypocalcemic state, parathyroid hormone is acting appropriately by increasing its level. Now, third condition is chronic renal failure, and there is hypocalcemia. And what happens to phosphate? It is increased because these are the salts which kidney has problem excreting. In chronic renal failure, there are several salts, phosphates, sulfates, and many other things actually which are retained. Phosphate is one of them. So once there is increased level of phosphate, that will again stimulate parathyroid gland and parathormone level will be elevated. This would be called secondary hyperparathyroidism. Secondary hyperparathyroidism in chronic renal failure is very common. One might think that this is the physiological adaptation, but we actually try to fix it. This hyperphosphatemia, we try to fix it, hyperphosphatemia, to correct secondary hyperparathyroidism, because this could lead to bone loss. So that was it. I hope I was able to give you a basic introduction of calcium phosphate homeostasis and the role of parathyroid gland, role of vitamin D, role of gut, role of bone in maintaining serum calcium. I hope you also understood this correction of calcium in the presence of hypoalbuminemia and hyperproteinemia. Please also watch my videos on parathyroid disorders, both separate lectures on the hyperparathyroidism and hypoparathyroidism, and a separate lecture on vitamin D deficiency. Thank you very much, and I look forward to see you in my next lecture. Thank you very much.